Welcome to our special mentored project presentation. My name is Yashi, our team is Vedha, Mia, and myself, and today we are excited to be sharing our research which we completed under the thoughtful mentorship of Dr. Amelia Sattler, Dr. Adrian Bakong, and the Stanford Care Leadership Team. Advanced care planning, abbreviated as ACP, is a critical part of managing care goals and quality of life for patients nearing end of life. However, providers face many barriers initiating these difficult conversations due to lack of consensus on which patients need ACP and when they need it. Our study specifically looks at two measures of ACP, the frequency of ACP conversations and ACP documentation within the high-risk patient category, which we've defined as age above 65 and having an end-of-life index score greater than 45. The end-of-life index score, or EOLI, is a validated tool that uses patient electronic health records to produce a 2-year mortality risk score that can help providers prioritize ACP for their highest risk patients. But before implementing the scoring index at Stanford, our team wanted to conduct a pre-intervention analysis to see whether disparities in the frequency of these ACP conversations and documentation exist across racial groups. Uncovering such a disparity across race would help justify the need for an unbiased data-driven tool like EOLI.
Our data is sourced from 7 Stanford primary care clinics and consists of patients ages 50 to 100. We've included patients who are 65 and older and have an EOLI score greater than or equal to 45, meaning they are at high risk of dying within the next 2 years. Our study population consists of 422 patients of 4 races and ethnicities. Moving on to our graphs, figures 1 and 2 look at what percentage of the study population have had ACP conversations or ACP documentation on file, stratifying by patient race and ethnicity. Figure 3 considers of patients who have had ACP conversations, what percentage of them also have ACP documentation. Our main findings from these graphs are that Asian patients are least likely to have ACP documentation in their charts. Minorities who have ACP conversations are also least likely to have ACP documentation in their chart.
As we can see, there are discrepancies in ACP, and the primary disparity lies in documentation. Additionally, among high-risk patients who have had ACP conversations, Asians are also less likely to have follow-through to documentation. This seems to indicate that providers are facing difficulties in implementing ACP directives within their minority patients, specifically Asians. One limitation to highlight in Figure 3 is that the Black and Hispanic patient counts are both below 10, therefore making significant comparisons about these groups more difficult to make. For our future directions, we also plan to stratify our data by providers to see whether similar trends across race exist for physicians as well. With our future quantitative analysis, we hope to include insurance as an indicator for patient socioeconomic status. Going forward, we hope to collect qualitative data using provider-facing surveys and interviews to assess perceived cultural and logistic barriers in the delivery of ACP.